Okay, we'll go ahead and start then. So, sorry. Good afternoon, everyone, and welcome to today's webinar, Nurses and Disasters. Are you ready? I'm Dr. Belinda Fleming, one of the nurse scientists here at Tennessee Center for Nursing Advancement, the sponsor for today's webinar. The Tennessee Center for Nursing Advancement is dedicated to supporting and empowering the nursing workforce across our great state. Our mission is rooted in advocacy, education, and collaboration as we work to strengthen the nursing profession, address workforce challenges, and ensure quality care for every community in Tennessee. We serve as a resource hub for nurses, healthcare organizations, policymakers, and educators, providing critical insights, tools, and initiatives to tackle current issues and prepare for the future of nursing healthcare. Whether it's through workforce research, leadership development programs, or partnerships that bring meaningful change, we are committed to advancing the role and impact of nursing in every corner of our state. Excuse me. Today's webinar is a chance for us to connect, learn, and explore how we can continue to make a difference together. Before we dive in and introduce our speaker, let me take a moment to cover a few housekeeping items for today's webinar. One, all participants, please remain muted during the presentations to minimize distractions. If you experience any technical difficulties, please use the chat box and our team will assist you. We encourage you to ask questions. Please feel free to type your questions into the chat box at any time during the presentation. We'll address them during the designated Q&A session at the end of the webinar. This webinar is being recorded. A copy of the recording and any shared materials will be sent to all registered participants afterwards, so you can revisit the information or share it with colleagues. It will also be posted on the center's website at tcfna.org. All participants will receive a participation certificate via email after the webinar. At the end of the webinar, you'll receive a brief survey. Your feedback is incredibly valuable to us as we continue to improve and deliver meaningful sessions like this one. Now, on with my introductions. So it's my pleasure to introduce today's speaker, Carl Mangum. Dr. Mangum is a distinguished psychiatric mental health nurse practitioner, educator, and healthcare leader with extensive experience in clinical practice, disaster response, and professional education. He holds a doctorate of philosophy and a board-certified psych mental health nurse practitioner, and is a national healthcare disaster professional. Dr. Mangum is also a certified nurse educator and a fellow of the Academy of Educational Excellence. Dr. Mangum serves as a team commander with the National Disaster Medical System of the U.S. Department of Health and Human Services, where he provides operational leadership in large-scale emergencies and disaster response efforts. His role involves coordinating multidisciplinary teams, ensuring clinical readiness, and supporting the delivery of behavioral health and medical services, in austere and high-impact environments. His professional interests encompass psychiatric and behavioral health, disaster mental health, healthcare workforce readiness, leadership development, and nursing education. Dr. Mangum is widely recognized his commitment to evidence-based practice, interprofessional collaboration, and preparing healthcare professionals to respond effectively in both routine and crisis situations. Through his combined roles as clinician, educator, and disaster response leader, he continues to advance excellence in mental health, healthcare, education, and emergency preparedness and response. So please join me in welcoming Carl Mangum.
Thank you. I didn't realize I did all that.
Yeah, well,
it's a lot. I'm tired now. Well, thank you for that great introduction. It is an honor to be with you today. And there's several things that we're going to talk about, and some of it's going to be quite obvious and like, well, I already knew that. But, sometimes it's good to be reminded of a few things as we go through and talk about things. And there are plenty of things to think about as you're thinking about preparing for disasters or responding to disasters. So let's just jump right in so we'll have plenty of time for questions at the end. See, there we go. What is went too far. There we go. What is a disaster? What is the definition of it? Well, a disaster actually has a couple of definitions. One is where the resources are overwhelmed, whether that's local, state, regional, or federal at the national level. And the local resources can be overwhelmed quite easily. A lot of times, for an example of that, I use at any given time in the Jackson, Mississippi metro area, there may only be 3 to 5 ambulances on duty throughout our metro system here. And so if a school bus turns over and they're injured, we're in a disaster situation because that would be more victims than we have ambulances for at the time. And so it only takes one incident, one thing to go wrong for us to be in a disaster situation. And it can happen very quickly, and it doesn't have to be, a very large scale thing to happen, as in a hurricane, a set of tornadoes, a large scale terrorist event. It could be something as simple as a school bus accident or a large accident on the interstate. So it wouldn't take much to, start overwhelming the system. The increasing frequency and severity of disasters globally. And this is one thing that makes the news a lot, is that we're seeing so many more things happen, from flooding to the tornadoes, to the hurricanes, to the man-made disasters with train wrecks, truck wrecks, and the terrorism that's going on throughout the world. Why is disaster preparedness a nursing priority? Well, just like the next bullet says, we make up the largest segment of the healthcare workforce, and without us, nothing happens. And so it's important that we as nurses prepare ourselves at home and at work, because there are times that we may have to stay at work and away from home, and our family still has to carry on at home. So it's important that we think about that and we prepare ourselves in both places. So let's quickly talk about some of the types of disasters. And again, this is part of that you kind of already know, but let's just kind of talk about it a minute. Hurricanes. Well, of course, in Tennessee, you don't have the direct impact of hurricanes like sometimes we do here in central Mississippi, but you do get the aftermath. And we think about that storm a couple of years ago that got part of eastern Tennessee and western North Carolina. And that hurricane caused a lot of problems with the flooding and the trees that it took down and things like that. So it can affect Tennessee, and it's one of those things you have to prepare for. And we saw the damage that it can do. Earthquakes, of course, with Western Tennessee being on the New Madrid seismic zone. And as we know, the largest earthquakes ever recorded in North American history, 1811, 1812, were on the New Madrid zone, where the Mississippi River ran backwards for 3 days. I don't know if you know that or not, but it did. And that's what actually formed Reelfoot Lake. That's on the Tennessee-Kentucky border. And so Tennessee definitely has to worry about earthquakes. That's one of those things that there's a consortium that involves 11 states, and Tennessee is one of them. Mississippi is one of them. But you need to plan and prepare for that. And that's one of the things that we're due for, a large earthquake on New Madrid. So got to prepare for it. Wildfires. Now, we think of wildfires, we think of out west, the western United States. And we don't think a lot about here in the Mid-South or the eastern United States, but this is where the eastern woodlands are at. And so if we have a wildfire and it gets up in the woods, as they say, it causes a lot of damage, and it can travel really, really fast. And so here in central Mississippi, most of our counties are under a burn ban right now, and they're under a burn ban until April 1st, and we've been under it for about 2 weeks now. So that's one of those things that you got to watch out for, because it can spread quickly, cause a lot of damage, and cause a lot of injuries. Pandemics. I don't think I really have to talk about pandemics a lot, but it can be more than COVID. Let me put it that way. And we don't really think about flu, but flu still kills more people than any other disease out there. And we still have to be cognizant of it and aware of it and take precautions against it. Now, let's quickly talk about technological and man-made stuff. Chemical spills, usually from trains, is where we hear that the biggest spills come from, or ships. But there are also trucks and things out there. The things like the shipping trucks, We think of a Walmart truck or those types of trucks. They carry a lot of different things, and they don't have to be labeled unless they have at least 1,001 pounds of a certain chemical. And so if you have 900 pounds of 5 different chemicals, it doesn't have to be labeled on the outside. And so if that truck has a wreck and those stuff mixed together, you could have a mess on your hands. We think of mass casualty incidents back to the buses, back to a large scale accident, back to a terrorist incident, which is the next bullet there. And we're seeing a lot more of those. The other thing that we need to think about, and my hospital can definitely speak on this now, um, about 3 weeks ago, really today is what, the 20th? So it was exactly a month ago yesterday, because it was the morning of the 19th of February. We were hit with a ransomware attack for the medical center. And we have a total of 7 hospitals, 35 clinics around the state. And we have, 7 schools. And we were all affected, and they had to shut down the whole the whole thing, the whole enterprise, as they say. And we our ER stayed open, our main hospital stayed open. The other hospitals remained open with their EDs remained open, but all clinics throughout the state shut down for about, they were closed for 11 days. All of our schools had to shut down, and we were closed for about 2 days. But then we reopened with the undergraduates, nursing mostly, and health related fields. They were able to reopen, but our graduate stuff remained closed for the full 11 days because most of that stuff's online, and it took that long to get us back in. That was one of those things that first morning when the black SUVs and the black helicopters started showing up, we had an immediate response from the federal government to come help us. And so it was one of those things that you're prepared for, but you're not prepared for until it happens to you. The funny thing of being an older nurse, or we'll say more mature nurse, how about that? That it didn't bother us to go back to paper charting. It was kind of easy, actually. Just had to, we knew that we had to sign off orders. We knew we had to sign our name. We could write a narrative, a half a page long. But the people that have become nurses in the past 15 to 20 years, they had problems. The people that have become doctors in the past 15 years, they all had problems. And so they got a crash course on how to sign off orders, that you had to sign your orders before you left them, so the nurses could carry them out and things like that. So those other man-made disasters, they can come about in many different ways. And I can tell you, if you work at a hospital or a clinic and you've not brushed up on how to work without electronics, you might want to do that. Just a word of encouragement there, because you never know when it's going to happen to you. Nuclear events. It's one of those things when you think about nuclear war, that's when you go to, but other nuclear events happen. We have, Grand Gulf Nuclear Power Station here in southwestern Mississippi. And that means most of the state is in the wind pattern that would be affected if there was a release of nuclear material from that power station. And so that's an issue that we plan for, train for, prepare for, and hope it never happens. But it's one of those things that we have to think about. When you're not even thinking about nuclear war, you're just thinking about a nuclear release on accident because of a nuclear power station. And so, and Tennessee is full of nuclear places and training and things like that go on. So it's one of those things you have to think about, be aware of, and that you plan for. All right, I'll move on here. All right, let's talk about disaster management as a cycle. Many of you have heard of the cycle of mitigation. That's where we're reducing risk. That's where we do things like we bolt things to the wall. That way, if we're in an earthquake, it doesn't fall on a human. Or we build levees to help prevent flooding. things like that. Those are simple mitigation things. Maybe not so simple building a levee, but those are mitigation things. We're just trying to reduce risk for damage or injury. Preparedness, that's part of the planning and training that we do to get ready in case something does happen. And that takes on many, many different things, and we'll talk a little bit more about that shortly. Response, that's the immediate life-saving actions that we take. We're putting what we've planned for and hopefully what we've mitigated for into action. Boots on the ground, as they say. This is starts at a local response, then it can move to a state response, then it can move to a regional response, then it can move to a federal or national response. And that's the order that usually happens. Speaking from a federal response person, we try to keep everything as local as possible. The federal government, as a responder, we don't come in and take over. We want the local people to remain in charge. We're there to assist you, especially in a medical standpoint. And I know our friends at FEMA feel the same way. We're there to assist you. What do you need us to do? What equipment do you need from us? And we want you and your people to remain in charge because you know your area, you know your resources, you know where you need your resources at. And so we want you to remain in charge and tell us what you need from us and let us come in and help you. But that's that immediate response. And then recovery, and a lot of times you'll hear this on television and news reports from various things around the country or around the world, and you'll hear the incident commander report out and they'll say, well, we've moved from a response to a recovery operation. And that's where they're stopped thinking of immediate life-saving things where we're maybe doing body recovery or we're doing additional evaluation and thinking of planning of removing the debris and planning on restoration of the area back to what its new normal is going to be, because I assure you it's never back the way it was. It's always going to be a new normal. Speaking for the Mississippi Gulf Coast from Hurricane Katrina, which was 21 years ago this year, it's not back to the way it was, and it'll never be back to the way it was. But it is at its new normal and continue to evolve. So when you think about the disaster cycle, mitigation, we're trying to reduce the risk. Preparedness, we're planning and training. Response is actual boots on the ground immediately after what's happened. And then recovery is after we can't save anyone else and we're preparing for the new normal. All right. The role of nurses. We talk about rapid assessment and triage. Whether you're part of the formal response or not, a lot of times we'll do this. If you're at a hospital or a clinic and you're part of that, you'll be doing triage there, I assure you. If you're part of a state or federal or regional response, someone's going to be doing assessment and triage. And it's one of the things, and we'll talk more about that real quick. A lot of people like me to talk about triage because you just don't get a lot of experience with it. And a lot of training on it. If you do, you get about 5 minutes in nursing school. And for many of us, that may have been 5, 10, 15, 20, 25 years ago. And if it's one of those things, if you don't do a lot of it, you forget how to do it. Participation or direct patient care under crisis standards. Remember, most municipalities, states, and the federal government, we have a different standard of care that can be invoked usually by the state health department or by HHS at the federal level under disaster type situations. And I've seen that invoked many times, especially after large scale hurricanes have affected several states or during COVID. And there were different standards of care based on the situation where you were at, how many people you had, how many people were injured, and the supplies that you had on hand. And usually, again, the State Department of Health will usually be the ones, here in Mississippi, it would be the state health officer. Each state law is different. Many times the governor will try to invoke that, but actually here in Mississippi, the governor can't. Only the state health officer can do that by law. And so it's important to know the state that you're in, the law for that state. So, but as the feds do it, it applies to everywhere, but it's based on what they have jurisdiction over. So it's one of those things that you have to understand where you're at, what's going on, and sometimes you just have to ask, hey, let me understand what I can and can't do. And when in doubt, ask. Okay. Participation in the incident command system. It's important as nurses that you learn the incident command, and there are plenty of courses that you can take under incident command, ICS, under FEMA. You can go online to FEMA.gov and you can find the independent study courses that are there, and you can take several of those incident command courses and learn how to follow incident command. It's important that in disaster response that you understand incident command, because everyone is going to be following it that comes in. I can tell you that. Your hospital is going to be following it. Fire, police, EMS, the feds, the military, everyone that comes in from the outside is going to be following the incident command. And it's important that people that are in command from the hospital or from the medical side understand it. And understand how to speak the language, so to speak. And people are required by law to understand that and take a certain amount of those courses. Your people that are in hospital leadership would know that, but they don't necessarily require everyone at the lower levels of response to take it. But I do encourage nurses to log into FEMA.gov and take those incident command courses. Communication with families and communities. This is one of the times that nurses will be some of the main people speaking with families and to the greater community at times, depending on the situation. It's important that we have correct information as we're speaking to them. And as nurses, as you know, still the most trusted profession in the United States for 25 years running since 2001, since 9/11. When firefighters were for that 1 year. It's important that we have the facts correct because they're going to be seeking out nurses to get information from, and if for no other reason that we're the most trusted. So it's important that we're prepared to speak and speak with good information. Ethical decision making in scarce resource situation. A lot of times we'll go through ethical decision making training through nursing school, but also through serving on ethical decision making teams and ethical groups or ethical committees within our hospitals, within our educational facilities or clinics. And it's important that nurses serve in this because we do have experience and training in helping making these ethical decisions. And I can assure you that in a large scale disaster, there's going to be ethical decisions that have to be made. And it's important that nurses have a seat at a table when that happens. Let's talk about some of those triage principles. Next few slides will be quickly on triage. Purpose, do the greatest number of good for the greatest number of people. And that's a simple purpose for triage. And as you're going through doing that and having to do triage in a large situation, which I've had to do in a small situation and I've had to do it in a large situation, that's what you have to keep in mind. As I'm going through making the decision, I'm trying to do the greatest good for the greatest number of people. And simply, that's what I'm trying to do. Start triage is one of the triage principles that's out there. That's the one I'm briefly going to talk about today. And there's several out there, but that's the one that we use to teach a lot of first responders, at least in our area. So you can look it up and learn more about that through the internet if you want to. Of course, they're color-coded categories. Most of you have seen that. We'll talk more about that in just a minute. And there are those altered standards of care during surge events that I briefly have already talked about. Here's adult triage with START, and I'm going to quickly go through it. If they're able to walk, they're a minor or green. You can go to secondary triage. If they're spontaneously breathing, you'd move down to check the respiratory rate. If it's less than 30, you'd check their perfusion, you'd check their capillary refill. And if it's less than 2 seconds, you check their mental status. And if they're able to obey commands, then they become a green or a yellow based on how they are. Um, and you can see that there. Now it breaks off to the right there. If they fail any of those, if they stop, if they're not spontaneously breathing, you reposition that airway twice. And if they do not start spontaneously breathing on their own, they become a black or expectant, and they're dead. We do not start CPR in large scale triage for large scale disaster because that would tie up resources and we just don't do it. This is where a lot of people say, hey, in day-to-day operations, we would. Of course, you would in day-to-day operations, but this is not. This is large-scale disaster where you have many, many, many victims, and we're trying to do the most good for the most amount of people. And if we stop to do CPR on one person and we have 50 victims, we're going to tie up 6 to 10 people doing CPR on that one person for at least 30 minutes. Those other 6 to 10 people could have saved, could have stopped the bleeding or other things that may have saved 4 or 5 other people if we'd have moved on. And that's the idea behind triage, doing the most good for the most people. If they do start breathing on their own, they become a red or immediate. The same thing as it goes down, if the respiratory rate's greater than 30, they become immediate or a red. If their capillary refill is greater than 2 seconds, they become a red. Or if they don't follow commands, they become a red. And so that's quickly, you should be able to triage people in 15 seconds or less. And that's what people don't understand, that you only have 15 seconds a person. You have to move on if you have a lot of victims. This is an example of a triage tag that we would use. There are, again, many of these out there. This is just one. You would tear off the perforated bottom, whichever one is left hanging that you would put on the person. That's what you've determined they are. So if you determine they're immediate or red, you would tear off the yellow and green. And a lot of times the person doing triage would put that in their pocket. And that way, when you get through and you pull them out, you would know if you had a yellow and a green in your pocket still hooked together, you know you had them as a red. So you would know how many reds you had, how many yellows, how many greens, how many blacks. So this is a color-coded system. This allows each person to have their own. So as they move to secondary triage or they arrive at a treatment area, they know what color they've been triaged as, and then they can move forward with that at the next area. This is kind of an idea of what we think about when we do entry to a triage area or we triage them where they're at. Then we have a casualty collection point, or if we have to move the victims away from that triage area, we set up a delayed area, an intermediate area. The walking wounded, the greens, you get them to help you. And then you set up an area for the dead. And you notice it's away from the other people. You don't want to set up an area for the dead with the people that are still alive. You try to have that separate from them if at all possible. And you try to have it separate from where the news cameras and the news helicopters and stuff would be flying over. And then you have a casualty collection point where ambulances or air ambulances would be landing, where you can quickly load people up and go. You don't, you can load the reds up because they're the immediates and they need to go first. But if you have room in the ambulance, say for 2 people to sit, you put a yellow and a green in there with them and get those people on to the hospital too at the same time. You don't have to send just all reds. Think, I've got more room in the ambulance, put other people in there that can just set up and send them on the way. That's quick, down and dirty triage, but things that you can build on. Core nursing disaster competencies, emergency preparedness knowledge, just overall the emergency preparedness response, knowing the 4 stages of emergencies, knowing what equipment you have to have personally, what equipment you need to have at home, what equipment you need to have for work and response. How to use PPE. Right now, unless people have just graduated nursing school in the past year and a half, I don't know how much training you need on putting on personal protective equipment, especially respiratory. but you need to make sure you know how to use all personal protective equipment in your facility or ones that may be issued with you. One deployment on the federal side during COVID, and I was sent all around the country. I was from one end to the other. I don't know if you remember the cruise ships, the first people that were brought into the country, the ones that were flown back from China, the Americans that first came in March of 2020. Those were the people that our teams took care of. And so I was in the first wave of helping take care of people. And many of our NDMS compadres that's what we did. I was in Maryland, I was in Wisconsin, I was in California. I ended up all over the place. But on our month deployment to Maryland, we had to be fitted for 4 different types of N95 masks because the state of Maryland and the federal government both were providing us with PPE, and it seemed like each week it would change because of what they were being supplied with. And so we had to be fit tested on every bit of it or we couldn't use it. And so we ended up with being fit tested on 4 different types of N95s. And so that's why I'm saying you have to know how to use the PPE that you're going to be used. And it's important that you know that because it's there to protect you. Infection control measures, you need to know that inside and out. Being a volunteer firefighter myself, that helped me a lot during COVID because I knew about hot, warm, and cold, and I knew how to set up those control areas and just use all my infection control stuff as a nurse and as a firefighter, and it just helped a lot. And I can tell you, you never know when that's going to hit and when you need to know it. Psychological first aid. If you've not had psychological first aid training, I encourage you to sign up if you've ever see it offered. It's important not only for you, but for the people you work with. It does help that I'm a psych MP, but it's important that everyone have training in psychological first aid, but because you never know who it's going to be. I've been one of those people where I needed somebody to talk to me, and I'm the person that teaches it. And so you never know who's going to need to be talked to. And it's important that everyone have training in psychological first aid because you just never know. I cannot stress that enough. And having cultural and vulnerable population considerations. Guys, we can end up anywhere in any type of disaster response. You never know who the population is you're going to end up with. You never know what you're going to be faced with. And I can just tell you, you need to have a broad understanding and you need to be able to adapt and you need to be able to be compassionate and ask the right questions and be willing to learn. And I can tell you through my career, I've had to do that so many times. And I just, tell you, just be pliable wherever you end up in a large scale emergency or a small scale emergency because your cultural and vulnerable populations are always going to be there. And it's something that you have to take care of. It's so important. Ethical and legal considerations, again, the crisis standards of care, it's important that you ask questions and make sure you're following the law. Your scope of practice during emergencies will change. We've seen so many changes back and forth, at least I know on the nurse practitioner side at the federal and state levels of what we can do and what we can't do. And I know some of those are even still up in the air in certain places, but it's important that you ask those questions. Don't be afraid to ask those questions and do it early and do it often if you have to. Allocation of scarce resources. Again, back to the ethical things. Do not be afraid to ask. Do not be afraid to say, hey guys, we have to talk about this. Do not be afraid to go up the chain of command. Do it. That's what we're known for as the nurses. That's why the public trusts us because they know we're going to try to do the right thing. Duty to care versus personal risk. This is something that I get asked a lot about. Do I have a duty to care? In your everyday job, if you take a patient assignment and you accept the assignment, yes, you do have a duty to care. If you're on the job and you show up, part of your job During a disaster and you show up because of your job, you have a duty to care. Yes. But versus that, if as a volunteer you show up, do you have a duty to care? Depends. Depends on how you volunteered and who you volunteered through. So if you're going home tonight and there's a wreck on the interstate and you stop to help, do you have a duty to care? No, because you're volunteering. You're covered under the Good Samaritan laws, and they're pretty much the same in every state. But you still have to only operate for what you've been trained to do and what you have the ability to do. You can't, if you're not trained in brain surgery, you can't do brain surgery. Okay. Versus personal risk. Are you to risk your life or bodily harm or bodily injury to do duty to care? A lot of times this comes up in active attack scenarios where there may be a shooter or someone with a knife or something like that. That's one of those things that, no, you don't have to. It's up to you and what decision you make at the time. No one can force you to put your life on the line to do that. Again, it's back to that's your decision. You have a duty to care, but nobody is going to force you to, take a bullet, so to speak, for your patient. And it's one of those things that it still may happen, but you don't have to make that decision to do that. You still may decide to do it, but duty to care versus personal risk is something you have to decide on as an individual. Many of us made that decision during COVID by entering rooms, even though we had our PPE on, it was still, we put ourselves at personal risk. And usually what I tell people, and I think it's on one of my later slides, is that, hey, our job is inherently dangerous of what we do as nurses. No matter what level you're at, LPN, RN, advanced practice, what our job is inherently dangerous of what we do. And some of us, it costs us our lives sometimes. And that's, that's a decision you have to make. All right. Psychological impact of disasters, acute stress reactions. I've seen this many times, even in experienced responders. There is a risk of PTSD, and it does happen. It's based on your experiences. Guys, just because you may have responded to 2 or 3 sets of disasters and nothing happened to you, that don't mean the next time it won't. I can assure you of that. You can plan and train and prepare all you want, but you have to be aware that each time you don't know what's going to be your trigger, and it can happen to you. Compassion fatigue. I have seen this many times in just day-to-day work, but if you're in a disaster mode for too long of a time, this can happen. And this is why it's important that all of us have that psychological first aid training so we can help each other and see this manifest in each other and help each other out. Burnout among healthcare workers. Most of us have seen this in our peers, maybe in our own selves. And it's something we definitely have to be aware of, especially in disaster settings. Importance of mental health support in our systems. When our federal teams deploy, we have a mental health professional with us. Each one of those mental health professionals that deploy with our teams are there for our team. They're not necessarily there for the public. They're there to support our team to make sure our team stays healthy. Now, does that mean if one of someone from the public needs to talk to somebody, we don't let them talk to them? Yeah, of course we let them talk to them, but they're there for team support. They're there for team protection, and so that's how important we think it is. And so, if you respond to anything, always have some type of mental health support there. All right, lessons learned from recent disasters. Nursing challenges from the COVID-19. I'm not going to go too much into that. There's just been so many, and we're still learning from that. Not enough nurses, not enough trained people, PPE shortages, staffing crises, which we're still facing, the emotional toll that it took on us, seeing that many people die in that short a period of time, not having enough resources of people, equipment, supplies, just you name it, we didn't have it. Innovation and resilience. We started wearing trash bags. I still remember putting my N95 in a paper bag and sticking it in the windshield of our cars because that's what the CDC told us to do. And I just remember us sitting in the car talking crap about the CDC. And the CDC was a fellow federal entity that works for the same people we do. And we were just like, are they nuts? Can you believe they're telling us to stick this up so sunshine can disinfect our mask? And we were just like, well, we're going to do it. And we're going to take some pictures of it to prove that we did it. But I don't think this is killing anything. But it was because we were going to run out of N95s if we didn't do it. And we did it. The thing is the straps would break after 2 days. So we never got 3 days out of them. So there's the lessons we learned. So now we've got N95s everywhere, but how many of them are going to go out of date before we have to use them at that level again? Who knows? We're still learning though. And so we'll see. Hopefully it's not anytime soon. Personal preparedness. Quickly, some things about personal preparedness. Know your facility disaster plan. You need to look at it. I know it's boring. I know you think it'll never happen to you. Well, there's somebody that's went through a hurricane at my facility, somebody that's went through a tornado at my facility, somebody that's went through a pandemic at my facility, somebody that's went through a ransomware attack at my facility, somebody that's went through a fire at my facility. Guys, it's going to happen to you, okay? It's a matter of when. Know your disaster plan. Understand it, okay? Participate in those drills and simulations when they come up. Maintain your certifications, BLS, ACLS, advanced trauma life support, all those things. Develop a personal and family emergency plan. Your family has to be taken care of at home. My kids are all grown, middle-aged adults now, thank God. But I have 8 grandchildren, and they live all over the country from the West Coast to South Mississippi. And so I help them maintain their plans. What are you going to do if you're stuck at a hospital or you're stuck at a National Guard base? And what are your kids going to do if you know, who's going to take care of them and things like that? So it's important that you have food, gasoline, emergency supplies, generator, tents, things like that at home, and a plan for your family. I had one always for my family of what they were going to do, how they were going to make it. And my wife was a teacher for many years, and how they were going to make it. And it was all set in case I was stuck at the hospital and couldn't leave. And that happened. That happened during Katrina, and it worked. And so you got to have a plan. Do you keep extra stuff in your car in case the disaster happens while you're in your car moving? You've got a plan for stuff like that. I keep stuff in my car and my truck. And you just never know when things are, I'm telling you, you got to plan ahead for that kind of thing. Don't let it catch you. Barriers to preparedness overall, limited training opportunities. We do not do enough training on this at our facilities, period. Whether it's a school, hospital, clinic, we don't do enough, period. I'm just telling you, I'm a proponent of more training. Resource constraints. We do not have enough resources to use to do this. We do not have enough time or material. Communication breakdown. That's the first thing that's always going to happen is communication breakdown. It's going to happen every time. You have to train for it. You have to practice it. You have to know it's going to happen, and you have to know how to overcome it. You have to know that workforce shortages are going to happen. People are going to leave whether they're supposed to or not. They're going to worry about their family, they're going to freak out, and they're going to leave. Okay? Calmness is a skill. You have to train for it. I have a whole other lecture I can do on that sometime. But calmness is a skill, and you have to train for it. Okay? It's going to happen. We're already short nurses already, or the whole world, but especially here in the U.S. But you're going to be short, especially in a large-scale disaster. All right, I might have to move a little quicker. Strategies to improve it, continue education. Simulation is a great way to do it. Have interdisciplinary disaster drills because no one group of people do a disaster by themselves. It's always interdisciplinary. Have community partnerships, hospitals together, clinics together, fire, police, EMS, train with everybody, train with construction companies. Why? Because they're the ones with the big pieces of equipment. When you need a big piece of equipment to move something, store something, they're the people with it. Be a policy advocate. Always. Disasters are inevitable. Nurses are important to all of this. Preparedness does reduce mortality and morbidity. Readiness is also a personal and professional thing. Are you ready? That's the thing. Commit to ongoing disaster preparedness. It's not a one and done thing. You have to do it constantly. You have to refresh your stuff. You have to go to additional training. You have to go to repeat training. Some of these are soft skills, and if you forget how to use a certain radio, or if you get to what red is, what green is, what yellow is, and how to do that triage, it's a soft skill and you'll lose it. There's some references. Quickly, I'm going to look through these just to remind you of some things, and I know some of these are a little old, but the Murrah building. This was a terrorist attack, Oklahoma City. There was one nurse that was killed during this. She was hit in the head by falling debris. The local hospital responded. First responders went there to help the fire and police EMS. Local hospital sent a team. She was in the area of the pile where she didn't have the training or the personal protective equipment, and a piece of concrete fell and struck her in the head and killed her. The Atlantic clinic bombings, the main thing I want you to remember about this is they were trying to kill the first responders. They weren't necessarily after the clinic nurses and people. They were after the first responders. And that's why they had the secondary. September 11th, I don't think I have to say anything. University of Arizona shootings. This was at the School of Nursing, and they killed 3 instructors and shot 2 others. This was by a student, and he had additional bombs and guns out in his Jeep. And this did happen. He sent a manifesto to the, I think it was the Arizona Republic newspaper. You can go back and look at that. It was a bad day. I worked here when that happened. Madrid, this was the train bombings in Madrid in 2004. The thing about this is they found one of the bombs that didn't detonate. And why didn't it go off? Because they had it set for PM instead of AM. So luckily the terrorists make mistakes. Hurricane Katrina, and that's the actual NOAA weather radio or NOAA video of Katrina's landfall. And that's part of the Mississippi Gulf Coast, or what's left of it. Guys, this can still happen. Luckily, we've not had a large-scale landfall in the past couple of years, but it's going to happen again. Mumbai attacks. I quickly want to talk about this. This has to do with Fahadeen attacks. These are terrorist attacks carried out by usually 8 to 12 terrorists that break up into groups of 3 or 4. This particular one was a series of 12 coordinated attacks by 10 members of this organization. A total of 175 people were killed. More than 300 were injured. 9 of the attackers were killed. 1 was captured. They used boats to come in from the water. They went to several different locations, including a hospital that they took over, hotels, businesses, restaurants, and things like that. And what they do is they carry not only rifles, hand grenades, and things like that, but they just indiscriminately just start shooting people, blowing up things. They take hostages, and their sole goal is to kill as many people as they can. And the only way to stop them is to kill them. They're not there to surrender. They're not there to negotiate. They are there for one reason only: kill as many people as they can before they are killed. And this is called Fahadeen attacks, and this is something that they're currently worried about. And so this is one example. There is a movie about this, but something to think about. This is not something that we think about or prepared for. And if something like this did happen in the United States, the problem is people would walk into this not realizing what it was, and additional people would be injured or killed. Hurricane Sandy that hit the New Jersey, New York area. And this is just to remind people, it's just not the Gulf Coast. It's everybody. I responded to Hurricane Sandy. The Boston bombing, anywhere, any place, anytime. You have to be aware. That's the main thing to get out of this. Tornadoes, severe weather, anywhere. Triage means to sort. Need to know all that. I've talked about a lot of this stuff. You'll get the copies of this, but I'm at that last slide. Preparedness is the standard. The business that we're in is inherently dangerous. Questions?
Well, sounds like we need a part two, Carl.
Sorry.
No,
Dr. Mangum, can you tell
Yes.
us about your work? I know you do some work with the government and what that organization is, and if somebody was
Sure.
interested in joining you, because you talked to me once and I was like, absolutely not. So
Yeah. All right. Well, currently I'm the team commander of Alabama DMAT. And actually, I just took over the Alabama DMAT team January 1st, a couple of months ago. Before that, I was a team commander of Delta One, which was Louisiana, Mississippi DMAT. And they actually did away with that team. They decreased the number of DMAT teams they had in the United States, and they took it down to less than 50 teams. So Delta One was actually done away with. And then they combined several other teams across the country. And so Alabama had two teams, 1 and 3, and they combined them just to one team, and their team commander retired. And so they asked me to take over that team, and I did. What a DMAT team is, and again, there's less than 50 of them now across the country. But their staff, they're a multidisciplinary team. We have doctors, nurse practitioners, PAs, RNs, paramedics, and then pharmacists. Those are the medical component, and then it's a commander, deputy commanders. Then we have an administrative officer. Then we have logistics people that make up the rest of the staff. And when we deploy either as a 35-person or a 50-person team. And we can set up a hospital pretty much anywhere in tents. When we deploy, we have enough supplies with us for 3 days. We can operate 3 days without any help from the outside. We have air conditioning, heating. We have our own food. It's MREs, but we have our own food, our own water. We have our own pharmacy. Of course, it's a limited pharmacy, but we can quickly get resupplied by the feds. We can set up in a field. We can set up in a parking lot. I've set up DMATs at a hospital, a Home Depot parking lot, a Hobby Lobby parking lot. I've set them up all over the place. The last one I personally set up, we were at Fort Walton Beach Medical Center after Hurricane Michael hit Panama City and Panama area. And we were at Fort Walton. We were the first hospital open west of all the damage. And we set up between their ER and their front door, literally in their parking lot. And so, and that's one of the things that we can do. We started seeing patients. That hospital was running at 156% of capacity when we arrived. They were getting their butts handed to them, basically. We saw 759 people in 13 days just in our tents, not counting what they were still seeing in their ER and in their hospital. We can run our own labs. We can do X-rays and stuff like that. We can do cast. We can run a code. We have all of that we can do out in our tents. We can't do a MRI or CT. We can't do that. We train with the military, so the way they load aircraft and helicopters, we do it the same exact way as the military does. The other thing that our mission is, and it's been our mission for 30 plus years, is I can't really say we're the backup to the military, but if there's a large engagement or a large war, especially this was really planned for Europe. If there was a large war in Europe and the medical parts of the military were strained, they would activate NDMS, the National Disaster Medical System. We would be activated and we become the bridge for the injured military members from OCONUS outside of continental United States back to CONUS, back to United States. So they would position us either in an area that they were receiving casualties. Let's just say we were in Britain and the war wasn't in Britain, say it was in another part of continental Europe, and the casualties were getting back to Britain. We would have people stationed there, and they would be brought back on military aircraft or civilian aircraft. Our people, medical people, would be the ones flying with them back and debarking them here at reception stations and making sure they were sent out to NDMS hospitals, which there are hundreds of NDMS hospitals throughout the country. Any hospital can be a member of the system in case of a large emergency, and that would be in case. So we are part of the system in case of war. We've trained to do it, but we've never actually had to do it. And but we are factored in as part of that response. So it's something we don't take lightly. We take it serious. And that's why we train with military and National Guard units. So we know how to load a C-17, a C-5, a Black Hawk, a Chinook, and we do it the same way the Air Force, the Army, the Navy, the same way they load it, same way. When the hospital ship went for Hurricane Maria, went to Puerto Rico, the USNS Mercy went, we're the ones that helped staff that ship. And so we would do the same thing if one of those ships were brought into play. We've already done it, but we would do it again. So that's kind of how we do it. We can be sent to any large-scale emergency like that disaster, but we also do national security events, things like the 4th of July on the National Mall. We're up there. My team, Delta One, our last term was in 2017. I can't believe it's been 9 years since we did it. But when the president does the State of the Union, there are teams that are, I'll just say, near Washington in case something horribly goes wrong. When the Democrats and the Republicans do their national conventions, there are teams usually in the vicinity. When the Olympics come in 2 years, there'll probably be teams near that. The Park Service, the Secret Service, all of them, if there's a national security event, they usually ask us for help because there are no other federal teams that are medical except for the military. We're the only medical teams the federal government has that can be mobilized, and we literally can be sent anywhere in the world. We've been to, we go to territories, Guam, Puerto Rico, been many times to both of those, but we have been international too, to other countries if the Department of State sends us. So that's it in a nutshell of what we do.
Thank you.
Yeah.
Any other questions?
I do have a quick question.
Sure.
Because I've been on a disaster team with the Red Cross for years, and unfortunately through many natural disasters. Where do nurses who are interested in this, where can they get training other than these volunteer organizations?
If you want training, really the training is through the federal government training. I can tell you that is if you want that type of training is at Anderson, Alabama. It's at what used to be Fort McClellan through the Center for Domestic Preparedness. I've been through most of their training there, and I didn't go as a Fed. I went as a state employee. And there's a lot of good training there. If you want some additional training, the New Mexico Tech has one for suicide bombing and things like that. Now you'll get more of the bombing part and not necessarily the first aid part, but it helps to know the other side of what to look for and where you don't become the victim. And that actually helped me out a lot too. There's the part at near Vegas on the radiation part. So all that's part of that national consortium that the U.S. Department of Homeland Security puts on, and all those are available if you sign up for it. It's my understanding all those are still up and going, although they were stopped there for a very short time during all the budget when it was being looked at. It's my understanding all of them are up and running again because they deemed that to be essential. The ICS training is definitely at FEMA.gov, and it's on there under the individual training. There is some of that if you advanced training like ICS uh, um, 300 and 400, some of that you have to do in person. But if you contact the local emergency management people, they can usually get you involved with that. A lot of times people say, well, I want to learn how to put on a tourniquet. Well, you usually learn that at a local area, either through the hospital, clinic, or Red Cross. Usually one of those are your local emergency management agency. The other area is that the medical response are those they're considered federal, but they're the medical teams that HHS has with local volunteers. Let's see, what are they called? The not the CERT teams, but the medical corps. And a lot of those are out the country, and they do a lot of training, but they're strictly volunteer. Where when I talk to you about DMATs and NDMS, we're paid. We're employees of the federal government. Now we're intermittent employees. We don't get retirement. We don't get all that. We're only paid if we're deployed. But we're considered federal employees. But we're the medical reserve corps. They're volunteers, and they're usually stay in their local area. Although there are examples where they've moved them from one state to the other to help. But most of the time they stay in their local area or their state to volunteer. And there are a lot of examples of that. And they do a lot of training too. On the federal side, our teams, I don't hire you as a nurse to teach you how to be a nurse. Hopefully you come with that. And we're going to teach you how to cook an MRE if you don't already know how to do that, how to set up our tents and how to do our triage and how to operate our equipment. And the rest of it you'll learn on the job.
Are there any other questions? Yeah, your DMAT sound like I'm retired Navy and I was in the Fleet Hospital.
Yeah.
So it kind of your DMAT sound a lot like Fleet Hospital. That everything arrives in crates and you hope the CBs get there before you do.
Yes.
But they don't always. So you have to know how to put everything together.
Exactly right.
Okay. Any other questions? I don't think so. I really do think maybe we need to do this again or have another half, part two from Dr. Mangum. But we do truly appreciate you taking your time out to come invest with us. And for those who came to the seminar, nurses came to the seminar, I hope you really got as much out of it as I did. I went to FEMA.gov just before we got on, just to kind of see what was out there. There were pages and pages of things to do and education to do. So I guess I need to get started. Before we wrap up, I want to remind the people who came to that you will receive an email shortly containing your participation certificate and access to the webinar recording. Additionally, in that email, there'll be a short survey, and we really, really would appreciate your feedback to help us improve and tailor future sessions. So without further ado, we'll say goodbye to Dr. Mangum, and I appreciate you so much. And hopefully you won't be deployed.